But in the meantime, we welcome all of your participation for these live events. So, Katie, what do you think? Should we start the program today?
Yep, you can kick it off.
Excellent. Well, it's my pleasure to introduce our not so guest. He's part of the family, but it's the first time that he's speaking today in this series, Dr. Tyler Kaplan. So, Tyler, how are you?
Doing well. Thank you for having me. Happy to be part of everything.
Excellent. Well, Tyler Kaplan is an MS-trained neurologist. He's a faculty member at Rush University Medical Center, and he specializes in multiple sclerosis and neuroimmunology. And then he now has a special interest in the research outcomes for the brain health program. So Tyler and I will start the conversation today by giving all of you a brief summary of why are these topics important? Why do we want to develop outcome measurements that are going to help us understand the disease process in more detail? So this is just to serve as a very succinct reminder of the incidence and prevalence of multiple sclerosis. We know that based on recent data, over 1 million individuals in the US and over 4 million in the world are diagnosed with multiple sclerosis. Most patients develop their first symptoms between the age of 16 and 45. However, as you know, there are pediatric patients that are diagnosed as well as individuals over the age of 45. It is a female a predominant disease like most autoimmune disorders, and the ratio continues to increase, currently thought to be 2.4 to 1. And we know that if we don't intervene, the outcomes could be devastating. And these numbers are based on natural history studies, so these numbers are based on individuals who never received medications for multiple sclerosis. And we know that 50% of individuals will require some sort of assisted device for ambulation, and 30% will become wheelchair bound. And in the past, we used to say that the lifespan was decreased by 5 years, but that's no longer true with the use of medications. We see that our patients' lifespan is the same as individuals without multiple sclerosis. But unfortunately, MS is the leading cause of disability in young women and the second leading cause of disability in young men from neurological disorders in the US. So this is something that we are invested in trying to stop the disease from progressing. And again, as a brief reminder of terms, we call a relapse as the presence of symptoms and signs that last for more than 24 hours, and they're associated with deficits in the absence of infection. So let me ask Dr. Kaplan, so what are the most common symptoms that patients can experience from relapses?
Yeah, sure. So, I think when we talk about relapses in multiple sclerosis, we can certainly have a really wide variety. But there are certain what we call kind of classic MS clinical syndromes. So, symptoms that tend to be a little bit more specific to multiple sclerosis as opposed to other things. So the kind of classic MS clinical symptoms we describe are things like optic neuritis, which is generally painful vision loss, usually with pain associated with movements of the eyes. And this can affect either one eye or both eyes at the same time, but most commonly affects one eye. Another kind of classic clinical syndrome is something called diplopia, which is just basically double vision, or if you kind of look in the mirror, you'll see that your eyes are not moving together the way they normally are coordinated together. And then some of the other classic presentations can be things like vertigo, and then also something called transverse myelitis, which is inflammation of the spinal cord. So that can often manifest with changes in sensation, changes in strength in the arms or legs, and then sometimes changes in things like ability to walk or bladder bowel function. But certainly each person's experience of MS is a little different, but when we think of some of the more kind of most common presentations, those are some of the big ones we look for.
Excellent. Thank you. And, another question that we usually get from our patients is the presence of symptoms that perhaps are not indicative of a relapse, and we call those pseudo relapses. So what are your thoughts about pseudo relapses?
Yeah, so certainly it can be very difficult even for trained professionals to be able to necessarily suss out the difference between the two. But I think classically when I talk to patients about helping to maybe delineate between a pseudo relapse and your more kind of classic MS disease relapse, there's a few things we think about. One is if there are external stressors going on. The classic one thinking about is infections, things like urinary tract infections, or certainly COVID more recently. So if patients have some sort of external stressor on the body, whether it's stress itself or infection or overheated or things like that. And oftentimes when we talk about pseudo relapses, they tend to last for less than 24 hours. So that's oftentimes a good metric we can think about using when we're kind of helping to delineate between a pseudo relapse versus a kind of a classic MS relapse.
Excellent. Yeah, timing is important, and also pattern, right? So usually relapses, the deficit continues to get worse over time, usually early on, where pseudo relapses, they are usually transient, short-lasting bouts of symptoms, and usually symptoms that already existed before from previous lesions. So Susanne is asking why the optic nerve, and we don't know exactly the reason why lesions affect different areas of the central nervous system, but there are classic locations, and the optic nerve being one of those. So most recently, we came with this term called relapse-associated worsening. And that's something that, is an attempt to understand what contributes to disability in multiple sclerosis. And there are two main contributors. One is the deficits that occur as a consequence of a relapse. And the graph here shows that very rarely there is complete recovery from those symptoms. And that amount of disability that is left as a consequence of each relapse over time accumulates. And that is one of the contributors to what we call relapse-associated worsening. And here is a representation of lesions. And, as you perhaps, as all of you know from being patients and doing MRIs frequently, sometimes, most of the times, lesions don't cause symptoms. And that's why sometimes you do an MRI as a way to do clinical surveillance. And there might be one or two lesions that were asymptomatic. But that one lesion that actually affects certain pathways in the brain or the central nervous system that we need may cause symptoms. In general, we say that supratentorial lesions, meaning lesions in the upper part of the brain, for the most part are asymptomatic. Whereas lesions, as you get narrow into the central nervous system, in the brainstem and in the spinal cord, may cause more symptoms. But there is another term that we often use, and is this concept of progression. So Dr. Kaplan, can you explain to us, what do we mean when we say progression?
Yeah, so I think that one of the big differentiators that we think about is progression is more of a kind of continual, gradual process in which you have worsening of disabling symptoms, and generally without a kind of recovery phase. So whereas in your kind of more standard relapsing MS, you have a rather acute new neurologic symptom or symptoms that develop over maybe a couple days or a couple weeks, and then a degree of improvement then over the next couple weeks or months, although maybe not complete improvement, but usually some degree of improvement. Whereas when we talk about progression, you don't necessarily have that pattern. It's usually much more insidious, much more gradual, can be over the course of months or even years. And then, yeah, without that kind of recovery phase. So a more permanent progression of disability.
And there is another term that we often use that is deconditioning. And this is nothing else but just this loss of physical fitness due to inactivity. And we saw a lot of that during the COVID pandemic in the early phases of it, where most of us were confined to an indoor setting and our ability to do physical fitness was reduced. So most of our patients felt worse. And it became difficult to understand, is this worsening due to deconditioning or worsening due to MS progression? And even though it's challenging clinically, we know that the conditioning is partially, if not completely, reversible when we can institute some sort of physical therapy or exercise program, where in a sense progression may be that steady worsening that may not respond as much, and I'm going to emphasize as much, to physical therapy, because we know that sometimes rehabilitation and training can even plateau or reverse some of those signs of progression. So this brings us to the next term. We spoke about RAW, which is this relapse-associated worsening, but the other main contributor to progression is what we call PIRA, or progression independent of relapse activity. So I hope this serves as kind of like a visual representation of the two main contributors to disability. On one hand is this incomplete recovery from relapses. On the other hand is this progression independent of relapse activity. So this is very briefly to review what constitutes the pathology, the why is this happening to me? Why is my immune system all of a sudden reacting against my brain cells and causing these things? Well, we still don't know the cause, but we know that like many autoimmune disorders, there is a point in which your immune system in a sense, start reacting against some of your components of the cells, in this case, the myelin. And that's kind of like where the genetic component of MS plays a role. There are certain genes that actually has to do with regulating these responses to self-antigens. But you still need a trigger, and that trigger there are many factors, environmental factors, that have been linked to a risk of MS. But perhaps the strongest one is infection with Epstein-Barr virus, the virus that actually causes mono. So now you have the perfect storm. You have these immune cells that perhaps are more prompt to cause autoimmunity, and now they get activated by something external. We also know that vitamin D deficiency may play a role. We know that smoking plays a role. Childhood obesity. So there are all of these factors that play a role in increasing the risk of MS. But now that you have these autoreactive cells, these cells that have been trained to go after something that looks like myelin, they're going to proliferate, they're going to replicate, and they're going to expand. All of a sudden now you have this army of cells that the only thing they learn to do is go after something that looks like myelin. And they will do that, and they will get to the central nervous system and try to find that myelin. And this is just a cartoon that on A shows what a picture of a brain could look like. So where you have these red dots being the wires or the axons, and you have the green circles around, that's myelin. And on B, you can see these immune cells represented here as these circles, these blue circles that are getting into the brain looking for that myelin. And if we do an MRI at that moment, you see these bright spots. So one of the questions here was, what is the frequency of MRIs and why do we do MRIs? So Dr. Tyler Kaplan, how do you use MRI in your clinical practice?
Yeah, so I mean, certainly MRI plays an important role in various different aspects of care of multiple sclerosis. First of all, it plays a primary role in the diagnosis of multiple sclerosis. The actual criteria that we use, a major component, a very large component of the actual diagnosis is based upon the findings based on MRI. And then also it can be used as a tool both to monitor for kind of long-term stability of disease. So while people are on a medication, you can monitor for the development of new lesions. And the reason we do that, even in the absence of new symptoms, is, and we're going to talk about a little bit later too, but what Dr. Nervali already pointed out, is that a lot of lesions, especially lesions in the top part of the brain, what's called the supratentorial white matter, can be asymptomatic, and so you may not necessarily have symptoms that are associated with them. So I will typically get MRIs, at a regular basis. It kind of depends on the individual person. Sometimes it'll be once a year, sometimes it'll be, every couple of years, kind of depending on an individual's experience. So there's no one kind of cookie cutter approach to how frequently to get MRIs. And then kind of the third way you can incorporate MRI is to assess for relapse. So to see if there are new enhancing inflamed lesions. So if somebody's having brand new symptoms, it can, so there are really kind of those three different modalities that we can incorporate MRI and in MS care.
Excellent. And we're now talking about acute inflammation. And what I just very briefly discussed is, the part of MS called acute inflammation. Can we measure that? Do we have the tools that allow us to know if our patients are having acute inflammation?
Mm-hmm. So, right now that's a big area of a lot of research as far as what ways can we accurately and efficiently measure acute inflammation. And we're actually kind of towards later on in the talk, we're going to talk about a new project that we're going to be launching here at Rush as far as a new unique offering that we're going to have to measure that. But right now, of course, the primary way that oftentimes that we do assess for acute inflammation is through MRI. But they're kind of burying the lead a little bit. But we're going to talk a little bit about some additional ways that we potentially may be able to assess that in a more efficient manner.
Excellent. And then we have another type of inflammation that we call chronic inflammation. And chronic inflammation is responsible for that progression that we discussed before, the progression independent of relapse activity, whereas acute inflammation is responsible for the relapses. So what is chronic inflammation? Well, once all of these immune cells get to the brain, they don't completely leave. There is not complete resolution of that inflammation. And some of those cells may continue to activate additional inflammatory components in the brain, a type of cell that we call microglia, that this activation of these cells called microglia may continue to slowly demyelinate. And some of these lesions, not all, but some of these lesions slowly expand and grow. And something that recently received another acronym, and it's fascinating how MS neurologists, we love acronyms. Every 2-3 years we introduce another term just to confuse our audience. But this acronym is SEL, S-E-L, and that stands for slowly enlarging lesions. And those are lesions that are thought to have some sort of activated microglia in the periphery. And we don't know exactly what differentiates this type of lesions, but it's possible that these lesions drive progression, and a progression that is compartmentalized in the central nervous system, that is independent from the inflammation in the periphery. There's another consequence of chronic inflammation, and some of these cells called the B cells, and perhaps our audience is very familiar with that if they heard of anti-B cell therapies, because B cells play a critical role in MS. And one of those roles is that once they get into the brain, they like to aggregate into clusters. And we call these lymphoid structures because they resemble the architecture that we see in the peripheral lymphoid tissue. So these clusters of B cells, we don't know exactly what they do, but very likely they have to do with this activation of chronic inflammation in the CNS. And all of that will result ultimately in degeneration. And one of the consequences of that is brain atrophy or volume loss. So going back to our cartoons, in C, you can see a chronic lesion with some sort of activated immune cells in the periphery. And then in D, you can see these chronic inactive lesions. With some of the more advanced MRI techniques, you could start seeing those slowly enlarging lesions, and you can actually measure with some of the software tools that we will discuss in a few minutes. But unfortunately, unless you have this specific software, you can't truly measure or quantify the volume of these lesions. And I briefly mentioned brain atrophy, and I want to discuss very basic topics here on brain atrophy. So we know that all of us, as we age, our brain is going to shrink. That's a normal process of healthy aging. And the volume change is approximately 0.2 to 0.4% per year. However, we know that multiple sclerosis without treatments, that rate of brain atrophy could be as high as 1.5 to 2% per year. And of course, certain medications, and most medications, but particularly those highly effective therapies, they have a benefit on reducing that rate of atrophy. And that's something that, depending on which medication we are using, that could be more of a similar rate to healthy controls, as we see usually with those highly effective therapies. So, and now I just want to put everything together that we've been talking, and this is just to conclude our very basic science review for today. So hopefully we can create that background knowledge to understand why are we so excited to announce two of our upcoming projects. So we discussed acute inflammation, and acute inflammation is responsible for acute lesions on the brain, but also for relapses. And as we discussed before, relapses contribute to disability due to that incomplete recovery. Dr. Kaplan is going to talk to us a little bit more about this biomarker called NFL, or neurofilament light, that has been linked to as one of those markers for acute inflammation. And as the graph here shows, acute inflammation is maximal early in the process of the disease. Now, the younger we are, the younger our immune system is too. And that's why we see that this immune attack is very active early on. And as we age, there's a process of aging also that happens in the immune system. And that's why you see that there is a decline in the consequences of acute inflammation. However, there's also this chronic inflammation. It's a term that has been hanging around in the last decade called smoldering inflammation, but it's nothing else but chronic inflammation. And that is what it's the process that explains progression independent of relapse activity, also known as PIRA, and perhaps the process that explains slowly enlarging lesions, brain atrophy, and certain biomarkers. So let me ask Dr. Kaplan one more question here. So when you're taking care of your patients, do you feel that you have all the tools that you need in order to understand what is driving disability in your patients?
Yeah, I mean, that's a very good question. You know, as far as do we have all the information we need, I don't know that I would necessarily say that. I think that, we're only, there are limits to what we can objectively measure in patients in terms of disease activity. I think in particular, where when it comes to MRI, kind of basic MRI technology, we're quite good at being able to pick up and measure the acute inflammation component of multiple sclerosis. Generally, especially in the early stages of MS, people having acute relapses, the MRI is a very sensitive, very useful tool in really being able to pick up those new areas of inflammation and really be able to pick up on that or not. So, but when we talk about this more progressive, smoldering, PIRA, kind of however you'd like to call it, inflammation, or the term I sometimes use is more compartmentalized, like this inflammation that's more specific to just in the central nervous system. Our abilities to measure that are generally limited in terms of, I think this is, a lot of patients can relate to this, where patients are experiencing worsening symptoms, worsening disabilities, but the MRIs really don't look all that different, or there's minimal, if any, change acutely on MRIs. And but that's where some of the new projects that we're talking about today kind of may be coming into play to help us more accurately be able to assess patients in ways that you can't necessarily get anywhere else, or anywhere else, I should say.
Excellent. No, and you're not alone. I have to say we all share the same limitations in terms of truly understanding how our patients are doing, to the point that I became very careful in using the term stable or remission, unless I truly have all the tools that will allow me to understand, are we truly certain that there is no progression that perhaps we are not capturing or not measuring under the surface. So now we are, in a sense, changing the way we approach patient care in MS, and we are becoming more nuanced. And when I say we, is the overall MS community in truly understanding what else can we do to identify progression beyond a traditional physical examination or a history. And I will say the last 10 years, the last decade, we've been trying to incorporate what is called patient-reported outcomes. And as the name implies, those are questionnaires or validated scales that allow us to understand things like fatigue and things like processing speed or cognitive decline, depression, anxiety, quality of life. And I know that Adrienne Castillo, she's using some of those patient-reported outcomes in her clinic to try to understand how patients are doing, not only from a symptom standpoint, but also from a functional standpoint. And even though that is very important, sometimes that's not enough to capture these pathological processes that are happening under the surface. So that's where MRI perhaps could play a role. And as we mentioned before, MRI is a great tool to look at acute inflammation, to look at lesions and enhancement as a sign of acute inflammation. But now it's becoming also a great tool to measure brain volume, to understand what is the rate of atrophy and also how that rate of atrophy compares to the expected atrophy based on age and gender. But also MRI, through the use of artificial intelligence, also can quantify lesions and allowing us to measure not only the number of lesions, but the size of the lesions, and if there is any change or growth that occurred in those lesions over time. So there is a platform called Icometrix, and just as a disclosure here, neither Dr. Kaplan or myself have any type of financial relationship with any of the companies that we will discuss today. It's always good to clarify that. But this is an FDA cleared image analysis that it's been used widely in research, and now is becoming more used in the clinical setting. And we are implementing that at Rush. It's going to take us probably a good 6 months to get it up and running, but it's been approved. And through Icometrix, we can actually quantify lesion volume and we can quantify brain volume. And this is an example of how that software is going to look like in real time, which you can see in blue or light blue that the algorithm is going to measure all the gray matter, that cortex, that cortical volume, and not only measure that, but also quantify the volume. And it's going to allow us to have a report that will tell us what is the exact amount of brain volume that patients have and how that amount compares to a range of healthy controls that has been corrected with age. So I think this is a powerful tool to truly understand and measure brain volume. So Dr. Kaplan, what are your reactions to these type of tools and how do you foresee using them in your clinic?
Yeah, so I think that having more objective way of measuring findings on MRI is going to really revolutionize our approach to actually addressing change over time, and as another tool in terms of assessing how effective our medications truly are. Because I think right now, when we talk about whether a medication is quote unquote working or not in somebody with MS, oftentimes the way we're measuring that is primarily based on the development of new lesions or the development of enhancing lesions. And basically, a lot of times if we say, well, if we don't see new lesions, we don't see enhancing lesions, the medication's working, the MS is in remission. But I think as we get more and more information about more of this progressive compartmentalized inflammation that can occur, and even in ways that maybe we don't see on like a basic MRI, being able to utilize these artificial intelligent ways of being able to more accurately and kind of put a number and objectively measure some of these more subtle expanding lesions and the like, that can give us a much better idea of ultimately how effective our medications are and allow us to be able to pivot based on that and seeing if we, maybe a medication really isn't as effective as maybe we think it is at the time, and being able to, maybe get out ahead of the clinical symptoms, allowing us to maybe change medication treatments prior to people developing worsening disability.
Excellent. And I see a question from Mark. Yes, so there is now a CPT code that radiologists can use to include this type of analysis. So yes, insurance should cover for the use of Icometrix now. And I don't know, Katie, are there any other questions?
You've been answering some as they've been coming in. If you want to, we can stop now and look at a few more if you have a stopping point in a couple minutes, whatever you prefer.
Yeah, let's do it in a few minutes because I have something else that is exciting or perhaps equally exciting.
All right.
And as you all know, we are very much in favor of a holistic approach to patients. As Dr. Kaplan mentioned, the medications play a critical role and they're extremely helpful, but there is more we can do for our patients. And that's where all of these lifestyle interventions that we've been discussing, the role of exercise and nutrition, symptom management is very important. So how can we capture all of that? Well, we can do that in the clinic, but also there is this app that we are working on having it available called iCompanion that actually integrates with the MRI algorithm. So it's something that we can actually offer to patients who would like to participate. And through this app, patients can actually input symptoms over time. The app can actually measure things like steps given on a given day. There are also games that patients can do that through these sort of games or computerized games, we can measure things like processing speed, memory, and all the different things. So these are examples of ways in which we can enhance the way we measure and track symptoms, track function, and hoping to also learn from things like lifestyle interventions, as exercise and number of steps, for example, correlates with any type of benefit in these MRI outcomes. We've been talking now for a couple of months on the role of exercise, and there is some evidence that the use of regular routine of exercise can have an effect in things like brain volume, thalamic volume, and so on and so forth. So having this type of tools is exciting also from a research standpoint, be able to quantify that in the real world. But there is more, and as Dr. Kaplan mentioned, an MRI is a wonderful tool, but there might be even things happening behind the scenes that the MRI cannot capture. And so can you talk to us a little bit more about the role of proteomics and biomarkers?
Yeah, absolutely. So yeah, and I think I saw there's some questions kind of hinting at this earlier. So I think what is important, and there've been a lot of different I guess examples people have used over the years when we talk about the kind of what's going on in MS disease activity. For a time, a lot of people talked a lot about this iceberg model that what you see is just a very small piece of what's really happening under the surface. And as we kind of talked about earlier, there are changes on the MRI that can happen without any symptoms. And then going a level before that, there may be levels of inflammation that are even below the threshold of what the MRI can pick up. And that's a very hot area of MS research kind of throughout the country right now, is this idea of, well, how can we catch and measure this inflammation even at lower levels? And that's where we get into this idea of biomarkers as a way of being able to more objectively measure inflammatory activity.
Excellent. And just for clarification, are you talking about blood-based biomarkers, spinal fluid? How can patients get access to this information?
Yeah, so certainly that's an area that's been studied both in spinal fluid and in blood. Now, of course, spinal fluid is not as easy to access, so it's not as practical. But we're looking to start with a new project here working with a company called Octave to provide a new serum biomarker panel. So rather than just measuring one biomarker that may or may not be as accurate, but incorporating a series of different markers, including one neurofilament light chain, which is something that has been studied for several years in MS, and we are able to measure, but it has its limitations as a single biomarker. So being able to incorporate multiple different biomarkers at the same time, because MS is a disease that functions on multiple different levels in terms of inflammation.
Excellent. And I like this picture because it shows, kind of like the three levels that we are talking, right? So the clinical level, which are the relapses and the progression, but also under that surface, we know that the MRI can capture more disease process than what we can actually see at the clinical level. And that's the whole point of doing MRIs, and now very soon improving the sensitivity of these MRIs to allow us to quantify volumes. But also there is under the surface on the MRI. We know that if you start looking at the molecular level or the chemical level, there are certain things that even with these advanced MRI techniques, we might be missing. And that's where the serum-based biomarkers, perhaps, and I'm going to use a big perhaps because all of this is very early and very early stages. But I think the big question is, can we clinically learn something from the use of these biomarkers that will be meaningful for our patients and allow us to capture, inflammation before that inflammation results in a lesion that perhaps results in a relapse. So I know that you've been working with this a company called Octave in trying to get it implemented. But how do you envision this being useful to our patients?
Yeah, so I think that there's a couple different potential practical ways that we could incorporate this test in. And what I want to just clarify is, as Dr. Miravalle pointed out, this is still a relatively new kind of tool at our disposal, and it's still we're still kind of figuring out how it's ultimately going to be most effective. Currently, how this has been validated so far, it's been clinically validated in assessing the probability that somebody will have a new enhancing lesion in their brain within 30 days. So that's technically the area that it's been clinically validated right now, but it's currently being studied as well to assess for more of the progressive or long-standing inflammation, what we talked about earlier. So there's that active inflammation versus the progressive, and those studies are still actively ongoing. But as you can kind of see here, this is an example of basically when you do this test, like the kind of this is one page of like what you would receive in your report. And what you can see here is in the middle here, this disease activity score. So essentially, this uses a kind of a complex algorithm incorporating 18 different markers in the blood, and they give you a number between basically 1 and 10 in terms of how active the disease is. And as you can see here in this example, they give this fake patient a 2.5. So low risk of them having active disease activity. And as you can see here, this is something that you could potentially measure over time. So not only could it be useful in an acute setting, if someone's concerned they may be having a relapse, that we could assess that relatively quickly, but it's also something perhaps that we could measure over time as a way, as a kind of a marker of how effective somebody's therapy is. So seeing, as the example you see here is this patient started up at looks like about an 8 out of 10, and then they went down to, looks like about a 5, and then they went back up to a 6. And then let's just say they started a medication at that time, and then you see they went down into this green zone. So that may be another way in the future that we can check people's blood over time to assess actually the effect that the medication they're on is actually treating their MS in an objective kind of data point.
And I love the fact that you use the term in the future, because I remember for decades we've been talking about this, and we've been asking for markers, and we've been kind of wishing we had these tools, and all of a sudden now we have them. and it's becoming extremely exciting to be able to offer them. However, as you mentioned before, we are still in the process of validation. We are not in prime time to truly even understand what is the role or utility of these measurements. And that becomes particularly important when we are looking at cost. So can you tell us a little bit more about how is this biomarker being offered currently? Is that covered by insurance? Is there any cost associated with that?
Right, very good. So yes, so as it stands right now with just how new this this marker is, it has not currently been approved by any private insurance plans. But the company right now is giving the test free of charge to Medicare patients. And then they have a sliding scale for people with private insurance or self-pay that is based on income. So they, we don't have the slide here, but we actually do have there is a pay scale that we can send out to patients if they're interested. And basically, depending on your income, it can be anywhere from $2 to the most expensive it would be $150. So somewhere in that range for that test, depending on your income.
And as you mentioned before, this is something that is just a blood test. And we are working internally to be able to have a system in which we can draw the blood in the clinic. So it's something that we are hoping that once, you know, all the requirements are being met, and we can now officially offer these type of tools. We're working together to try to facilitate the use of whether it's the Icometrix for the MRI as well as the Octave panel for the serum-based biomarker. So what I'm going to do, I'm going to stop sharing, and then perhaps we can go over some of the questions or comments from our wonderful audience.
So I'm going to try to go in reverse order here because I do think you touched on a lot of the questions that were previously asked when you were giving the front of the presentation. But one question that was just submitted was, if we're on Ocrevus, which are or some other similar treatments which are often considered best available, how will this information, either the AI MRI report or Octave report, change your treatment plan? In other words, is this information giving us info we can't do anything about yet?
That is one wonderful question, and you know, I'm curious, Dr. Kaplan, what's your opinion? But mine is going to be like, well, at least I take this as additional information, and I hope we don't get to a point in which a single test determines the approach of care, because as we learned from many decades in MS, when we arrive to a recommendation for MS, is usually based after, you know, a comprehensive understanding of the patient's needs, the different circumstances around that. So it's more than just a single test. So I don't think we're going to get to a point in which a result of an NFL biomarker is going to drive decisions on therapy. However, it's adding more information to the picture. And if we have a patient that is clinically worsening, that feels that there is progression, and then all of a sudden we receive from the app that fatigue increased and ambulation decreased, and we do an MRI and the brain volumes are worse, and then we do the biomarker studies, and all of a sudden we have all these markers of chronic inflammation going up. Well, now we have a better understanding that there is indeed progressive MS, and perhaps we need to act on it. But what do you think, Dr. Kaplan?
Yeah, you know, and I think something to keep in mind is, you know, when we talk about kind of the tiers of treatment for multiple sclerosis, you know, generally we talk about high efficacy versus like platform therapies. And when we kind of make those designations of which medications are high efficacy versus not, that's based on primarily clinical trial data. And MS clinical trials primarily are focused on those acute relapses. That's their measurements they're looking at, are changes on MRI and actual clinical relapses. A lot of the clinical trials, very few of the clinical trials measured a lot of these more objective measures. only one or two of them that I can think of even measured brain atrophy. So in terms of, so even though we say, okay, we have this group of high efficacy drugs and we don't necessarily say one is head and shoulders better than the other, but maybe going forward with these additional data points that we can measure, maybe with additional research, we're going to find that some of these medications do work better in these more progressive forms of MS. We just don't know yet because they haven't been studied. So it's good because we didn't have the tools to study it in an objective measure. So going forward, we may actually be able to designate between the efficacy of some of the drugs that right now we can't say for certain that one is better than the other.
Excellent. Are there any other questions, Katie?
Sort of a combination of a bunch that were asked, and you touched on it a little bit, but could you give sort of an overview of when this might be available to patients and sort of what that process looks like for them if they are interested in getting involved with it?
Yeah, so I can take that one. So yeah, we are in the process. So right now, because like we said, this is a relatively new process, we are working ultimately. The ideal situation will be at some point we will get it incorporated into our central lab at our clinic so that when you go to our lab, like you're going to get your regular blood work, they can just draw the blood there and send it off. We're still working to get that incorporated. In the meantime, as a kind of a temporary measure, we are looking to incorporate bringing in a phlebotomist into our center. And ultimately, I think we'll be planning on setting up a program where we will set up a schedule for 1 day a week where patients can come in just for like a 5-minute nurse's visit to do the blood draw in our clinic itself. So obviously it's not as convenient as just being able to go to a lab and just get it drawn. And we don't plan on that being the long-term plan, but just as kind of a proof of concept to allow us to show that the demand is there, that then we can get it incorporated into the larger Rush laboratory system. So once we kind of get it set up, when we can start having patients get scheduled, then we'll be sending that information out to patients so they could, if they're interested, they could get scheduled to do that lab draw.
And similarly for the Icometrix for MRI, we got the first layer of approvals at Rush, and now we have to kind of work on all the details to make sure that it's been a smooth process that is incorporated into all the MRI sites at Rush. That perhaps will be the only requirement that I'm aware of now, that the MRIs have to be done at Rush or part of the Rush system, because we won't be able to apply this post-processing analysis on the software on MRIs acquired elsewhere. But then, so I anticipate perhaps 6 months and trying to be conservative on that estimate, but you never know how things can get delayed. But I'm very hopeful that soon we should be able to offer these. And as briefly mentioned before, will be a part of standard of care, so will be covered by insurance.
Great. I know that, we just got one more. Would this help to tell if there's a way to tell the increased risk of PML for JCV virus positive patients that are on immunosuppressants?
What an excellent question. No, as Dr. Kaplan mentioned, this biomarker tool has not been validated for safety. But we do have, ways to stratify the risk of PML by measuring things like the JC virus titer, and then including that calculation, things like duration of therapy and prior use of immunosuppressants. So there are different ways by which we can estimate the risk of PML, but unfortunately, I don't anticipate this biomarker tool to help us. However, we are still learning, so perhaps in the future we might learn otherwise.
One more. For the MRI brain volume measure, do you need a special MRI, or could you use the quote old MRIs?
So no, so the basic requirements to be able to deploy this analysis are the same as what a typical MRI will be done for multiple sclerosis. So the sequences are the same. I know that once this is approved and implemented, any future MRIs will include this analysis by default. So there is nothing different that we will have to do. However, if we want to use older MRIs and apply this software, then I'm sure there's going to be some sort of conversation with radiology because in that case, there might have to be some sort of way to build insurance for something that happened in the past, which may become extremely difficult. Having said that, we are hoping to initiate also a research program. So all of these offerings are going to be available to any patient at any time if they wish to do that. In parallel to that, we are working on a research program that will allow us to be a little bit more stringent on the outcome measurements and the design of the study, so we can actually get more data from it. So those individuals who are willing to participate in research, then we should be able to offer perhaps additional pieces of information, even from prior MRIs, if that's exactly what we're looking in terms of the study design.
So I know participants can send questions individually to panelists, so I'm not sure if you both got any personal questions in your Q&A or inbox or chat, but from my end, you've touched on every question that I've been sent so far.
I think we did, and we are getting to the top of the hour. So Dr. Kaplan, thank you for your participation today. Thank you for everything you do for our patients, and you've been doing for now many years.
Oh, well, thank you. Yeah, thank you, Augusto. Appreciate it. And yeah, excited about getting all these new projects up and running. And I forgot to mention earlier, but yeah, once we do make the biomarker panel available, we're going to be the first MS center in Chicago that's going to offer this, because currently it's being used in about 30-ish major academic MS centers. So we're excited to be able to offer that to our patients for the first time in Chicago.
That's an excellent news, and the same with Icometrix. So we're the first site in Chicago area to offer this. So we are extremely excited and proud of all this work, and very, very pleased to be able to offer that to our patients. So with that, I would like to conclude today's presentation, and stay tuned. We are planning something equally excited for March. You're going to receive an invitation in the same format, which is through my chart. And again, I would like to thank the entire Brain Health team, Adrian Castillo, Kathy Kiefer, Katie McGrath, and of course, all of the wonderful faculty members at the Rush MS Center, and have a wonderful rest of the week.
Thank you, everybody.